will continue until this year.
Sergey,
yes.
We are still seeing the first slide. Have you moved?
Yes, it's slide number 2 with the timeline.
I'm just seeing the first slide. The title.
And now?
We are still seeing the title only.
Interesting. Let me check what. No changes?
We see you, we do not yet see the screen.
What about now?
Can you share the screen?
Let me do it again.
Okay. No.
Strange.
Okay.
Can you see my screen now?
Yes, we can see the screen.
And what about now, if I open like this?
No, we see just half of, like, one part of the screen, one part of the slide. Yeah, that one is better.
Right?
Yeah.
Okay. Sorry for that. I don't know what's going on. So that was the slide I was talking about, and this slide shows the timeline of the glass development, how we come to this point where we are revising the glass. And you already told everything about the upcoming online, the ongoing online technical discussions and upcoming technical consultation in April 2021. So as I said, glass was evolving, and now it became quite a complex system. Sometimes we already call it glass environment. So how the glass 2.0 looks like? It has several distinctive parts or domains. First, of course, we are going to continue the routine data surveillance. And we call it routine because here surveillance based on the data that are routinely collected in countries for many different purposes, starting from the clinical purposes. And of course, a major part of glass will remain the antimicrobial resistance surveillance, which is now called glass AMR. I already mentioned that antimicrobial consumption surveillance was added recently, and in October this year, we started the first ever glass data call for antimicrobial consumption data. This part of glass is called glass AMC. In addition to the routine surveillance, we have what we call focus surveillance. And the first module in the focus surveillance domain was the emerging antimicrobial resistance reporting and risk assessment module, which is called glass EAR. Now we started the early implementation of the surveillance protocol for surveillance of antifungal resistance in Candida species in patients with bloodstream infections. This protocol is early implementation, but it's already ongoing. And at the initial phase in the enhanced gonococcal antimicrobial surveillance, glass eGASP, which complements the existing routine surveillance of resistance in gonococci. And this is the approach which involves collection of many additional clinical and epidemiological variables, and also collects the raw data on the resistance, because with gonorrhea, we are lacking clinical breakpoints to interpret the results of this susceptibility testing. And the third domain is additional surveys and studies. One example is the One Health surveillance, and I'm sure that many participants are aware about the project which is called Tricycle. We also included in this domain point prevalence surveys of antimicrobial use in hospitals. And here we also included the GLASS methodology for estimating the AMR burden, and specifically the protocol on estimating the attributable mortality from AMR, which Barbara will be telling in the second part of this webinar in the coming weeks. So the GLASS AMR manual, the second edition of the GLASS manual, it's just about AMR. So please be aware that we have separate documents for methodology of surveillance of antimicrobial consumption and other modules that I was talking about. So this document is about surveillance of antimicrobial resistance in humans. It went already through several peer reviews. So this is quite an advanced draft. But it's still open for the feedback. And that's why we are not finalizing the document before we analyze the feedback from countries and from national experts. So this document is part of a package of documents and tools which inform the implementation of the second version of GLASS. It describes the objectives and methodology of GLASS AMR. It provides guidance for countries on the methods for surveillance of antimicrobial resistance and the metrics these methods will produce. This manual is written for national GLASS focal points, for national public health professionals and national health authorities responsible for AMR surveillance of humans, but we also believe that those who are contributing to national surveillance data collection could benefit from this. And the document we also believe may be useful for national professionals from other sectors supporting surveillance of AMR in the context of the One Health approach. So what's new? I would say that there are no really dramatic changes. It's not like we are trying to introduce completely new methodology, completely new approach. But there are some new things added, and we added new specimens, we added cerebrospinal fluid, we added respiratory samples, which is of course challenging, but we believe that some countries may be able to generate data from this type of sample. And also we added non-genital samples for surveillance of antimicrobial resistance in gonococci. This is rectal and pharyngeal swabs. We added 5 new pathogens, Pseudomonas aeruginosa, and during the whole period of the early implementation of GLASS, countries were asking why we didn't include Pseudomonas aeruginosa in the first place. We also included the salmonella that cause typhoid and paratyphoid. And we included 3 pathogens causing meningitis. And of course, there are challenges. This is Neisseria meningitis and Haemophilus influenza, but these are important pathogens. And I will tell later why did we include them in the GLASS methodology. Of course, we included new antimicrobials to describe the resistance of the newly added target pathogen, but also to include both first and second line antimicrobials according to the WHO-aware antibiotic categorization. We also spent some time and effort to ensure that the GLASS methodology is described better. And also we introduced the approach of GLASS to assess and improve the validity and representativeness of the surveillance data. So this approach is introduced to guide interpretations of the data reported by countries and to monitor development in the national surveillance system and their quality. There are two other major additions. One is an option for submission of anonymized individual patient level data, which provides additional opportunities for AMR surveillance data validation and analysis. And there is also a new option for submission of data generated by molecular AMR diagnostics to complement phenotypic AMR diagnostic data and improve understanding of the underlying mechanism responsible for antimicrobial resistance. What are the objectives of the GLASS AMR and the GLASS in general? As before, we believe that the major goal of GLASS is fostering national surveillance systems and harmonizing global standards. Of course, we will continue to monitor global AMR trends in common bacteria causing infection in humans and inform the WHO model list of essential medicines and the aware classification of antibiotics. There is an objective to estimate the extent and burden of AMR globally by selected indicators, detect emergent resistance and its international spread, generate data to inform the implementation of prevention and control strategies and assess the impact of interventions, and inform research and development of new tools for the prevention, diagnosis, and treatment of human infections caused by fast-growing bacteria. The concept of the GLASS AMR core components proved to be quite useful in assisting countries to build or further develop their national surveillance systems. You may be familiar with this picture and the difference between this one and those you already saw in the GLASS reports and in the GLASS manual first version, is that we try to indicate that the surveillance sites ideally should include different types of healthcare facilities, starting from tertiary hospital through different levels of hospital care to outpatient care. We explained better the GLASS surveillance methodology and surveillance approach. We defined the population under surveillance, which remains the population composed of patients seeking care in healthcare facilities for whom clinical samples are collected for routine microbiological investigations, including species identification and antimicrobial susceptibility testing. The surveillance methods assume that data to be collected through a system which gathers results from susceptibility testing for targeted human bacterial pathogens, isolated from clinical specimens sent routinely to laboratories for diagnostic purposes. Together with the patient's microbiological results, species identification, and AST, countries are also invited to report demographic and epidemiological variables, either in aggregated or individual level format. And this is one of the most distinctive features of GLASS. We are trying to move from purely microbiological approach to surveillance of AMR to a really public health approach, which involves understanding of the impact of AMR on human health. There are somewhat different approaches that GLASS is fostering, and they come with the understanding how the human population is organized in terms of the targets for surveillance of AMR. Of course, in the total population of mostly healthy people, there are always people with symptoms, and some of them are seeking care in healthcare facilities. Those who are suggestive for infectious condition, they're tested microbiologically. And this is the population that we call population with tested samples. Of course, some of the samples, they produce positive cultures, and this is another subgroup of patients. And in some of these isolates, in these positive cultures, we see the antimicrobial resistance. So the most traditional approach practiced by all existing surveillance networks that existed before GLASS is when we look in the patients with the positive culture, with the growth of specific pathogens, and see what are the proportions of patients with the resistant pathogens. And that's what we call isolate-based surveillance. But the thing is that still, even if it's the lab that takes the most responsibilities for doing AMR surveillance, like unfortunately still the case in many countries, we still can measure the population with the tested samples. And this is an opportunity to have a denominator and start calculating frequencies of infection caused by resistant pathogens. And that's the approach we call sample-based AMR surveillance approach. So next slide is just another way to show the same definition of the surveillance approaches that GLASS is practicing now. So for isolate-based surveillance, we collect AST results from patients for bacterial pathogens and antibiotics under surveillance. The same goes for the sample-based approach, but here we add a denominator. And this is the number of patients from whom samples have been collected for microbiological testing, independently of the results. This means that both patients with growth and without growth of the bacterial pathogens under surveillance are included. The isolate-based approach metric is the most common, and this is simply the proportion of drug resistance. For example, it could be number of patients with bloodstream infection caused by E. coli resistant cefotaxime out of all positive E. coli isolates, which were tested for resistance to this antibiotic. Adding a denominator in the sample-based surveillance approach, we can calculate both the frequency of infections caused by specific pathogen under surveillance and also calculate the frequency of drug-resistant infections caused by pathogens, which is much better indicator in terms of epidemiology, understanding the actual contribution and coming towards the understanding of the role of specific pathogens in human pathology. This is how it looks like, the frequencies I'm saying that we could calculate with the sample-based approach. On the left, the graph shows the results from testing patients that are of community origin. And on the right, these are patients with infection that are associated with healthcare. You can see, for instance, that we can see the role of Acinetobacter in causing infections in bloodstream, both in community and hospitalized patients. And of course, it's not surprising that Acinetobacter, which is really not important in community infections, is one of the major pathogens in hospitalized patients. But we also can see that, for instance, the resistance becomes much more important for Acinetobacter in hospitalized patients because this is one of the most frequent infections. Even if we saw high resistant proportions in Acinetobacter in community patients, it wouldn't be so threatening because the frequency of these infections in the community is low. But in hospitalized patients, we see that both the frequency of infections caused by Acinetobacter and resistance in these pathogens are really worrying. So I already mentioned that we added some new specimen types. And in GLASS, specimen types are proxies for specific types or specific localization of infections or infection syndromes. So blood is a proxy for bloodstream infections. It was on the GLASS from the very beginning, but now we also added cerebrospinal fluid, which is also important for trying to see what's going on in the patients with meningitis. And for some regions, including African region, this is a very important type of infection. We keep urine, which is a proxy for urinary tract infection. We keep stool samples, which is a proxy for infection of gastrointestinal tract. And as I said, we added lower respiratory tract specimens, which are proxy for pneumonia or, let's say, infection of lower respiratory tract. And as I said, we added rectal and pharyngeal swabs for surveillance of resistance in gonococci. The list of glass target pathogen is longer. So as I mentioned, we added Pseudomonas aeruginosa, we added 2 new meningitis pathogens, meningococci and Haemophilus influenza. Now we are going to make a distinction between non-typhoidal and typhoidal salmonella. And of course, the list could be longer, it could be shorter, but this list is developed with several criteria in mind. So we are aiming to cover common bacterial infections, which are both could be associated with healthcare or community acquired. And of course, we choose the pathogen that cause life-threatening infections, but we also choose some pathogen that cause foodborne infections and could be used as a common indicator for the surveillance in humans and in animals and the environment. And for instance, these are E. coli and Salmonella, which could be used as a common indicator in One Health surveillance. Of course, we are considering the public health burden on infections caused by this pathogen, especially when they develop multi-drug resistance. Some pathogens are important because they affect vulnerable population. For instance, Haemophilus influenza was chosen because they can cause severe infections in children. And basically, most of the glass target pathogens are included in the WHO Global Priority List of antibiotic-resistant bacteria to guide research and discovery and development of new antibiotics, the so-called Priority Pathogens List, which was published in 2017. And what's important, this is the list of target pathogens for global reporting. Of course, the priorities for local and national surveillance, they may include other organisms and other antimicrobial agents, and they should be addressed, even though they're not yet requested to be reported on glass. So on one side, of course, we expect countries to consider the glass pathogen for inclusion in the targets in the national surveillance system. But of course, we understand the need that many countries may have to include other pathogens that are priority according to country specifics. So this is how the glass target pathogen belong to different specimen types. And of course, most pathogens are isolated from blood collected by glass. But this table helps to understand the link between specific pathogen and specimen types collected by glass. As I said, we have a list of drug-bug combinations selected for global surveillance. I cannot show everything because this is quite a long table included on the glass manual. But these are antimicrobials, detection of which reveals the most important antibiotic-resistant mechanisms. And of course, a consideration was given to antimicrobials that are commonly used and are available locally and nationally. So in total, we selected 32 antimicrobial drugs. And according to the AWARE classification, 11 are in the access group, 18 are in the watch group, and 3 are in the reserve group. And 18 antibiotics are included in the current WHO essential medicine lists. We did what we probably wasn't clear about in the first version of the glass manual. And we explained clearly in the new manual that the glass AMR list of target antimicrobial pathogen combinations is selected by glass for global surveillance purposes. So this list is not intended to guide testing or prescribing practices. This is very important. The list also doesn't imply that all of the included antimicrobials should be routinely included in AST by clinical laboratories. Of course, if the testing to any of these antimicrobials included in glass is performed, the results should be reported to GLAS. But also the list doesn't mean that these are the only antimicrobials recommended to routine AST for the organism body site combination. Of course, we made an attempt to select a small number of representative drugs for each antimicrobial groups. There are similar drugs in the same categories. For instance, we have 4 carbapenems offered for global reporting. It's done on purposes because different labs in different countries will often test just one of the drugs in the group, and they may change which drug they're testing. So that's why we have several representatives of specific class in the GLAS list of antimicrobials. So this is another way for looking in the difference between the isolate-based and sample-based approach, because different data sets reflect these differences of the approaches. So when we go with the isolate-based approach and collect just AST results for bacterial pathogens under surveillance, this data included in the what we call RAS dataset. But when we can also obtain the numbers of patients with both positive and negative results, that makes what we call a sample dataset. And here is the reminder to those who are new to GLAS what is included in these datasets. So the RIS dataset, which is included in both isolate and sample-based surveillance, it collects some data, of course, on the reporting country, on the year of data collection, on specimen type, pathogen, but also gender, what we call infection origin, community versus hospital origin, age group, and of course antimicrobials and interpretation of susceptibility testing results, including results that were not obtained. So number of isolates where we don't have any susceptibility data. That's important to analyze the whole submission. And of course, the data set will be divided in subsets if the countries have several different surveillance systems or some distinctive sub-region in the country that should be reported separately. The sample data set is built on the same principle, but it includes a very important variable, which is a number of tested patients. And as I said, this is the denominator we used for calculating frequencies of resistant infections. I mentioned that for the first time, we offer anonymized individual level data submission. Some countries, for instance, countries participating in the European and Central Asian surveillance network in the European WHO region, they already practice this anonymized individual level data submission, as well as the European countries which are part of European Union. And we believe that offering this approach would allow us to better manage and validate data, because aggregated data which are currently collected, they limit dramatically the possibilities for validation analysis of data. Sorry. We could start monitor the occurrence of multi-drug resistance, analyze the combinations of different antimicrobials and resistant to them. And this, of course, is critical for informing research and development of new therapeutic diagnostic tools. We can explore additional data analysis stratifications and generate state, province, or regional statistics by including facility identifiers. We could better analyze drivers and risk factors linked to resistance. We could generate transmission trends using both spatial, genetic information, improve capacity for outbreak detection, and provide several additional ways to assess data quality. The thing is, of course, GLAS will keep reporting aggregated data. But one of the functions of GLAS is helping countries to better analyze and validate their data. And that's when this anonymized individual level data submission would be quite useful. The individual data set will include, again, the obvious variables such as reporting country, certain identifiers, and of course they will be encrypted before coming to GLAS. We include such variables as hospital department, and we include also both interpretations and specific measurements of AST, zone diameters, minimal inhibitor concentrations, and here we also included selected molecular indicators. Also, we need countries to indicate what standards we use for stability testing, whether it was CLSI or UCAST. For the individual data submission, we also expect submission of additional denominators, which may be used for the individual data level data set. And you can see the list of possible denominators. Of course, we don't expect all of them to be reported, but ideally, we would expect that all these denominators will be quite useful to calculate additional metrics, which individual level data submission makes possible. We keep collecting data on the status of national surveillance system. This data proved to be quite useful, and they're important for us to see how we can assist countries to build or strengthen their national surveillance system. These are important indicators, and we'll be collecting them again. We provide a new infographics for the GLASS AMR data flow. While it's not changed from the one published in the first GLASS manual at the surveillance site level, at the national level now, you can see that we expect that countries may be reporting either aggregated data or anonymized individual level data, or even both. But what we added to this picture is that we try to more clearly explain the role of WHO as one organization with all the three levels, and to make sure that the very important role of regional offices is highlighted in this diagram. With GLASS developing the global standards and producing global reports, but it also relies on the regional and country offices, which work directly with countries, supporting their capacity building and producing regional reports. We will keep, of course, developing the GLASS IT platform. During this early implementation, it already changed. New models and new interface were added, and of course, it will be evolving to accommodate all these new methodological approaches that we are adding in the GLASS manual 2.0. So we also added some new indicators, and this is a Sustainable Development Goal AMR indicator. This is a proportion of bloodstream infection in more patients due to MRSA and E. coli resistant to third generation cephalosporins. And this is a very important, this is a Sustainable Development Goal of AMR indicator, and GLASS is already collecting these indicators, and we will keep this in the new version of the GLASS AMR. This is the illustration from the recent GLASS report, and you can see on the right here that GLASS is already collecting data on the E. coli bloodstream infections resistant to third generation cephalosporins. And you can see also the very diverse results coming from countries. The situation is different, but still the median resistance is quite worrying. So this indicator is very important. Here I would stop because the next part of the presentation today is about enhancing the representativeness of AMR surveillance. And this is the responsibility of my colleague Barbara Tornenbene. And as I understand, we now have some time for questions and answers. Thank you for your attention.
Thank you, Sergey. Thank you for the presentation. So far, we have 2 questions. I'm going to share the screen so that we see the questions or comments. Do you see my screen? Hello?
Yes, we can see it.
Okay. So there is a first comment from Dr. Moses Borongei from Liberia. He's saying, thanks for the update. We adapted the GLASS tool to include CSF won't swap in the baseline 2019 in Liberia. And he's saying that there is a need to ensure flexibility in the new GLASS to allow other specimens that are not GLASS priority pathogens. So I think this is a comment. If you have anything to say about it, you can still comment, Sergey. Thank you.
Thank you for the comment. And as I said, for the global reporting, we still limit the specimen types to what I just explained. But of course, as I said, we do understand that countries may want to include other important specimen types, like for instance, wound swabs and other materials. So we also understand the need. And if there is a need to discuss it further, I would offer an opportunity to set up a conference call, Zoom call with the country and see how we could be able to help with developing the tools for data collection to include other specimens. Over.
Thank you, Sergey. There is another question from Japet. He's saying, is the encryption of facilities done automatically, or should it be done by National Coordinator Center? Over to you, Saiki.
Well, it's obvious that we cannot take the responsibility for encryption because the data we receive there should already be encrypted. So this is formally a responsibility of the reporting NCC. But the good news here is, for instance, countries that are using HONET, they could use a feature of the HONET which allows to produce already encrypted data sets before submitting to GLASS automatically. And also, we are working on ensuring that all the IT tools recommended by GLASS, they also provide the possibility for encryption of data. Over.
Thank you, Sergey. I didn't see any other question or comment, but in the meantime, if there are others coming, they will be shared at the end. So I would like now to invite Barbara to present on data representativeness and sampling strategies. Barbara, over to you. Thank you.
I'll share my screen. Can you see my screen?
Yes, we can see your screen. Maybe
I'm just going to try and put it in presentation mode. Tell me if it gets too big for you guys.
okay.
Is that okay?
Yes, it's okay. Yes.
Doing this funny. What can you see? Can you see everything or just?
It's not yet in the presentation mode.
I don't know how to get out of this actually. I present a view now.
Yes.
Perfect. So as Sergey has mentioned while introducing the new or the updated GLASS approach, he briefly touched on biases that might impact the quality of the data that are collected by a routine surveillance system. So a surveillance system based on samples that are routinely collected for diagnostic purposes. As Sergey has shown before, GLASS is also developing specific surveillance studies. But in relation to the routine surveillance approach, we're also developing a number of protocols that might help enhancing the quality of the data collected by the systems. The first one is actually called the GLASS protocol for enhancing precisions and representativeness of AMR routine surveillance. So the way that we went on deciding what to design in terms of bias, well, first of all, we tried to find, or we looked for, what are the characteristics that an AMR surveillance system should have. And a successful AMR system should be able, sorry, I'm just going to move this. A successful AMR surveillance system should generate comparable, representative, high-quality data of pathogens of concern for the target population. And in particular, a surveillance system should be sensitive. So where sensitivity is the ability of a surveillance system to detect true events, true health events. So in terms, in a certain way, the representation of the precision of the system. Specific, and the specificity is how it's shown by how infrequently the system detects false positive health events, and again this chipping into the precision of the system. A system should be timely in the way that the occurrence of an adverse health event and the report of the event to the appropriate public health agency should come at the same time or overlap, and it should be representative. So the system should, a system that is representative, accurately observe both the occurrence of the event over time and the distribution by person and place of the event in the population at any point of time. So what we have seen in terms specifically for systems that collect data generated through routine diagnostic is that they often lack, or they're limited in terms of precision. And in this particular case, is because a limited number of AST are performed, or in general results are reported. So the impact on the precision of the system, so the sensitivity and specificity of the system. And they often lack or have limited representative because of sampling bias. So for example, the data are collected just from one specific healthcare facility or for a very specific group of patients and so on. So when we started thinking about these two major biases, then we looked at a way or a method to try and minimize the lack of precision and the lack of representativeness. And we decided to go by defining a sample size or benchmark number in terms of the number of results that we need for the system to be precise, and to define a sampling strategy that will ensure representativeness of the population that is under surveillance. So this method is actually built upon the current GLASS approach. So it's something that can ameliorate in a way the current GLASS approach, and then can be used together with the GLASS approach that Sergei has just presented. So it complements the continuous AMR surveillance system that are based on routine drug susceptibility testing. The target population remain, as Sergei mentioned before, the population of patients who seek care in the healthcare facility with a suspected infection, who are cultured and tested for identification in AST for routine purposes. So it's exactly the same target population of the normal GLASS approach. And we suggest that this approach, this method is introduced when the country can reach at least 70% of testing coverage of the national population. In reality, this is a suggestion, it's a percentage that we will work, we will think about and we will test it. But basically we know, and we will present that in the next actually slides, that many patients might arrive at the healthcare facility with symptoms, but for some reason they actually are not sampled. So if we cannot assure that at least 70% of your patients actually get a sample, then these methods to enhance precision and representativeness might fail anyway. So let's look at the benchmark. So the benchmark, or the sample size, is basically the minimum number of patient results that you need to obtain by the end of the year during your surveillance period. And it has to be the minimum amount of patient bacterial isolation results. So it has to be both positive, with positive or negative growth, but we need a minimum number of microbiological results from the patient. And within the group of patients with growth, we need a minimum amount of patient AST results. So as I said, in order to reach a specific precision, we need to have a minimum amount of result both for bacterial isolation and AST. This number, this sample size, normally depend on the expected prevalence of the defined infection that you're looking for and the nested AMR infection. So for example, you will have an expected prevalence of bloodstream infection due to E. coli, and by an expected prevalence of bloodstream infection due to E. coli resistant to third generation cephalosporin, and by using this expected prevalence, you can calculate the minimum amount of number of patients that needs to be blood tested and for which microbiological isolation has to be done for E. coli, and then the minimum number of patients with an E. coli infection, bloodstream infection, for which AST results needs to be done. It is particularly important for those syndromes for which patients are not always sampled, for example, urinary tract infection, or for those samples that are taken but are not always sent for bacterial isolation and AST. So it's really to maintain a strict criteria on the number of samples and tests that have to be done for the surveillance system to be precise. Then we look at representativeness, and as we said before, often the surveillance system capture only a subgroup of your population, and in order to minimize bias related to this, we can include the sampling criteria. In this case, we have suggested, for example, to obtain patient results from different geographical and administrative areas, so to have a good geographical distribution of the sample coming from your patient population, and possibly a good representation of samples coming from healthcare facility that provide different type of care, and not only tertiary care or secondary care or primary care, because we know that in particular for resistance, there is an impact, or there is a bias that emerge from the type of healthcare facility where the data are collected. And you will see when the protocol will be, I'm not going to go into details for this, but we have proposed a stratified proportional to site cluster sampling. It might be a little bit funny and complex, but it will be explained in detail with all the steps that the country needs to take. And here I just put an example of how the sampling might occur in a country, for example. So here we have a country X with a million of patients seeking care per year. The benchmark sample size for bloodstream, for bacterial isolation for a specific pathogen, a specific specimen. So again, it could be E. coli in blood, is being calculated, and it resulted in 1,000 patients. As I said, this is just an example. You don't have to take this number as, fixed number. It's just an example that we use. We use a sample size calculation. So let's assume that we have 100,000 patients for which we need bacterial isolation results. And then we have the 3 provinces in the country. And you can see that the number of patients to be cultured is being calculated proportionally on the side of the patient seeking care in each country. So in each province. So for example, in province A, we have 200,000 patients seeking care. So proportionally, the number of patients that needs to be cultured is 20,000. And again, you can see province B, 100,000 patients, 30,000, and 500,000 patients, province C, 50,000. So this is what it means to sample proportionally. So you sample in proportion of the number of patients that actually are distributed in your provinces. And then you again sample proportionally of the number of patients that attend to different type of healthcare facility. So for example, in province A, we can see that 10% of these 200,000 patients attend tertiary care facility, 30% secondary care, and 60% primary care. So you just calculated the 10% of 20,000, the 30% of 20,000, and the 60% of 20,000, and you get the number for each type of care, healthcare facility care, the number of patients that actually need to have bacterial isolation result for the pathogen and the specimen that you're looking for. So in this case, bloodstream infection. And you have to look for E. coli, but it is not important is that at the end you have a growth or a negative result. Both are results. And then based on this population, you can then go and calculate the number of AST results. So again, the protocol will again put more example, and we can work together on this and, you know, see how difficult it is to implement it. So the second protocol that we are designing, so as we said before, we have a routine surveillance system for which we are sure that the patients are tested. And so we just work on precision and representative. But what happens when actually we are not sure if the patient that comes to an healthcare facility are actually not sampled? And you do understand that if the patient are not sampled, we introduce quite a large bias because there's a big or a relative part of the population for which we don't actually have any result. So we have designed this protocol to estimate the tested coverage of suspected bloodstream infection. So what we call tested coverage is basically how many patients that come with suspected bloodstream infection actually get a blood sample taken. So we have said before that a surveillance system that is representative have to reflect the population characteristic relative to the place. And we have said that GLASS requires AMR data to be collected through a surveillance system which gather results and for bacterial isolation and AST from priority human bacterial pathogen isolated for sample clinically sent to routinely to laboratory for clinical purposes. But then we also say, what about if actually these samples are not sent to the lab because they're not taken, or because simply they're not sent because the lab is not available? And it's very difficult to obtain already a representative sample from the population, even when all the criteria of sampling are met. But we know that empirical antibiotic therapy without taking culture or an affordability of test, particularly when the test has to be covered by patients, are common, is a common occurrence in many low and middle income countries, but actually not only in low and middle income country where this issue, but also in high income country where it's basically the clinician that take the decision if the patient has to be sampled or not. For example, for urinary tract infection, normally empirical antibiotic therapy is suggested also in high income countries, and we lose a lot of results and data by doing that. So we have chosen to start the development of this protocol concentrating on focusing on bloodstream infection because they're among the most significant causes of motility and mortality worldwide by patient and old age group. Bloodstream infection is defined as the growth of microorganisms from a blood culture obtained from a patient with clinical sign of infection where contamination has been ruled out. And however, we know that, as we said before, either the patient might not get tested because of empiric antimicrobial therapy without taking culture or unaffordability of test, or because some selection bias occur. For example, the clinical perception of the attending physician might have an impact, cultural belief, available sources, and so on. So such practices, as we say, can lead to bias estimated of the proportion of not only the proportion of AMR bloodstream infection, but the proportion of bloodstream infection in the population, independently from the resistant patterns or not. So here we have presented, just to clarify where the bias are coming from, a summary of the diagnostic pyramids that needs to develop for actually a patient to obtain actually the patient AST results. So we know that initially we have a large group of patients that might seek care, healthcare service in healthcare facility. Then this group becomes smaller because we have then the patient with clinical symptoms of bloodstream infection. Then again, this group become again smaller because we will need the patient to be tested. As we've seen, that might not happen all the time. And then within the patient that actually tested, we will need, patient that actually go through the bacterial isolation for which the pathogen is correctly isolated. And again, from this, the AST result. So you see that from the big population that starts and enter in your healthcare facility, how this population then decrease until we actually get to the patient with AST result. And for each of these steps, there are possible bias that are involved. So very briefly, I'm not going to go very much into detail for this. We have designed this protocol keeping in mind as an outcome the estimation of the proportion of patients with suspected BSI that did not undergo blood sampling. So patients with a set number of clinical signs that we have defined that, however, are not blood sample. And we have chosen to use two approaches. One is passive case detection, where the clinician can look at retrospective data and medical records to see actually if there is an overlapping between the clinical signs that have been recorded and actually the sampling, the diagnostic that this patient received. And prospective approach with active case-based sampling, where the research team actively search for patients with suspected bloodstream infection, clinical signs, and then it basically observe if the patient have been sent for a sample to be taken or not. And this is quite interesting because by using this prospective approach, then you can actually compare this data with the data that you're already generating from your passive surveillance data and actually see if there is a discrepancy and adjust that either when you go to the next surveillance cycle or during the analysis of the data. So in conclusion, the two huge detailed protocols soon to come. We're very excited about this. And again, as I said, these are two protocols that complement the AMR routine surveillance approach. And with this, I thank you and I open the floor to questions. Thank you.
Thank you very much, Barbara, for this brilliant presentation. I tried to look into the Q&A chat. So far, I have one question in French. The question is about, let me share the screen. The question is about, do you see my screen?
Oui.
It's about
Méthodologie par l'OMS pour la surveillance de la résistance de l'E. coli dans la communauté. Okay.
It's a question about.
Yes, I understand.
Okay.
Dans la communauté, correct?
Ouais, je pense que
The methodology, the WHO methodology for surveillance of E. coli in the community. So people are asking which methodology WHO is proposing for the surveillance of E. coli in the community. Thank you.
So as we have explained with Sergey, at the moment, the methodology that we have for the routine approach has a very specific target population, and the target population is actually the population of patients seeking care in the hospitals or in healthcare facilities. However, as Sergey has mentioned, GLASS is starting to develop specific surveys and studies, and it is in the pipeline, the development of point prevalence surveys for community level, at community level. So I think we will probably start with, well, it will never be, it should never be pathogen specific. It should be syndrome specific. And as you know, the specimens that Glass has listed are actually a representation of the anatomical site for which we look the infection coming from. So urine, it's a representation of urinary tract infections, for example, and blood is bloodstream infection and so on. So when you have to start looking at the prevalence or the incidence or anything of in our case of an infection, you should start from the infection origin trait. So for example, we're going to start developing something for urinary tract infection. Then of course the pathogens are going to be the Glass pathogens that we collect for urine. So in this case, E. coli and Klebsiella. And one of the protocol is going to be for community level infections. But it's on the pipeline, and I don't know if Carmen wants to complement on this.
Laetitia, est-ce que je peux répondre aussi en français ou je dois parler en anglais?
Oui, réponds en français, comme ça, au moins on aura une réponse en français.
OK. Et surtout parce que le collègue de Madagascar a fait la question en français. Et bien sûr, ma collègue Barbara a déjà parlé et que nous sommes en train de aussi développer des stratégies de surveillance qui puissent complémenter la surveillance de routine. Ça veut dire, justement, je pense que la collègue a soulevé une question très importante qui est le manque de diagnostic de l'étiologie des infections communautaires. Il est clair que la méthodologie Glass, comme Sergei et Barbara nous expliquaient, elle comprend la population qui vient dans un établissement de santé. Et très souvent, on sait aussi que cet établissement de santé a un ambulatoire. Donc, la population peut aussi être une population qui vient à l'ambulatoire d'un hôpital ou n'importe quel établissement de santé peut être surveillée en utilisant la méthodologie Glass. Et pourtant, on sera en train de voir les infections communautaires. Un autre volet où aussi on peut avoir une idée des infections communautaires, c'est justement dans la méthodologie Glass, on essaie de voir et on demande cette information si les spécimens du patient a été collecté avant ou après 48 heures d'hospitalisation. Ceci, c'est justement pour prendre en charge les patients qui arrivent aux urgences et qui pourtant viennent de la communauté avec une infection communautaire, la plupart. Et donc, ce type d'infection aussi, on considère comme d'origine communautaire. Donc ça, c'est déjà dans la méthodologie actuelle de Glass, on a déjà des mécanismes pour essayer de comprendre l'étiologie et la susceptibilité des infections communautaires. Maintenant, pour, disons, d'une façon plus précise, complémenter les informations des infections communautaires, nous sommes exactement en train de développer des stratégies qui sont des enquêtes dirigées à des problèmes comme les collègues de Madagascar ont soulevé. Par exemple, ils sont concernés vis-à-vis à une maladie. Je suis d'accord avec Barbara. Les patients ne viennent pas avec le nom d'un pathogène écrit sur les fronts. C'est toujours une syndrome infectieuse. Donc, pour un syndrome infectieux, comme par exemple les infections urinaires, il est très important d'avoir une idée de quelle est l'étiologie pour qu'on puisse avoir aussi la directive des traitements empiriques. Barbara a mentionné que dans les pays riches, très souvent, les infections urinaires, on ne fait pas la culture parce qu'en réalité, pour la plupart des cas, ce n'est pas nécessaire parce que numéro 1 sont des cas pas compliquées d'infection urinaire. Et numéro 2, très souvent dans ces pays, ils ont déjà fait des enquêtes pour avoir une idée de quelle est l'étiologie plus probable et pourtant orienter les traitements. Donc, pour répondre au collègue de Madagascar, oui, nous sommes en train de développer ces stratégies pour l'utilisation d'enquêtes. Et merci beaucoup pour cette question, parce qu'une fois que les dessins d'études, des enquêtes seront prêtes, on serait assez content de collaborer avec les pays qui veulent tester, appliquer cette nouvelle approche que GRACE va implémenter tout bientôt. Merci beaucoup.
Merci beaucoup, Carmen. Je vais encore partager l'écran. Il y a un commentaire de Moses plutôt, de Liberia. Heidi, thanks again for the presentation. I heard you made a point. You made of point prevalence survey. Liberia is in the process of conducting PPS in healthcare facilities and would appreciate any data collection tool to facilitate the process. Carmen, tu peux commenter là-dessus encore?
Est-ce que tu peux... Oui. Okay. Well, I think that absolutely I could answer, but perhaps my colleague Barbara would love to answer this question, because exactly the protocol on attributable mortality, I know that it is not being presented today. It will be in the next webinar on antimicrobial resistance surveillance methods. It's exactly a protocol that uses, it's a kind of prevalence survey. So Barbara, would you like to comment on this?
I'm not sure if the colleague, so as Carmen mentioned, we have designed a protocol that looks at actually attributable mortality for bloodstream infection. And I'm not going to go into details about sample size, but normally the number of results that you have to obtain to actually estimate mortality is so large that it's also served for estimating prevalence. So it just automatically, while we're following the patient for the crude mortality estimates, we can also calculate the prevalence. I'm not sure if the colleague is talking about an IT data collection tool or a questionnaire. For the mortality study, we have developed specific questionnaires because it's not just for the mortality, but also for the prevalence. It's very important to collect what we call covariables, so factors that might actually have an impact on the estimation of these metrics. And so we have developed a very long questionnaires with core variable and optional variables that can be used as a guide for the type of data that needs to be collected. In terms of IT collection tool, we are brainstorming with our colleagues from our IT manager and the team lead that it's the head of our IT development on the choice of the best tool that we could then offer or to the countries to help them actually collecting the data. It can be done with Excel in a way, but of course that renders the data management much more complex. So I'm not sure if the colleague is looking more at the type of variables or data that needs to be collected, or the IT tool actually that is needed for the data collection. I don't know if that you want to clarify that, or if I was already clear in my response.
May I make a suggestion?
Sure.
Teacher? I think we received two interesting questions from Liberia already. And as I said, I would love to discuss them in more details over a specific call, Zoom call, so we can set it up and have a good discussion to see how I can assist these efforts in Liberia in a better way. So this is basically an offer to set up a discussion over.
Okay, thank you very much. Thank you. I think there is we have no more question.
Leticia,
yes, Carmen.
yeah. If there is no more question, and if you allow me,
yes.
I would like to make a comment. While I have been listening to these very interesting presentations, I think there is one comment I'd like to make about a point that Sergey mentioned. That is a very important point that I'd like to highlight. Sergey, at a certain point of his presentation, he mentioned that the global data that GLASS reports, so the variables and the global data that is reported, is for surveillance purpose and should not guide the local treatment. So it is absolutely true, because these are data from different countries, different contexts that may have nothing to do to the context in your specific countries. So the GLASS variables, the GLASS standards, let's imagine a hospital or a healthcare facility that is applying the GLASS methodology. Then this healthcare facility should be using this data. And of course, if the data, the collection of samples from patients is not a type of collection that is biased, as Barbara has just presented. So if the collection of samples is representative of the infections that the healthcare facility is seeing, then this data is the data to be used for guiding local empiric treatment. So just to make this clarification. So one thing is the data that you'll be using GLASS standards, and of course adding other pathogens, adding other specimens, or adding other bug-drug combinations according to the needs of your hospital, of your location. This data is exactly the type of data, if it is representative, that you can use to inform empirical treatment in your country. So please bear in mind that the use of the data in this case is precious, but in first place for you, for the countries, for informing the infection control strategies and for informing empiric treatment if the data is representative. So we should just be clear that it's really like gold, but it's like gold at the local level. Please, we cannot use the data from other countries and simply try to think that we can use this data to guide our treatment in our own country, okay? So this is the point. Thank you, Leticia.
Thank you very much, Carmen. I can see there is no more question. And I would like to once again thank the audience, thank the participant for joining us. And I want also to take this opportunity to wish you a Merry Christmas, a Happy New Year, and a a very nice 2021, which is different from 2020 without Corona. Je vous souhaite un très joyeux Noël, une bonne fête de fin d'année. Je vous souhaite une année 2021, une année de paix, de joie, une année où nous n'aurons plus de Corona, ou alors, en tout cas, nous n'entendrons plus parler beaucoup. Et j'en profite pour vous souhaiter à tous de très bonnes fêtes dans vos familles, vous remercier pour tout le travail que nous avons fait ensemble durant toute cette année 2020. Et je félicite également les pays qui ne cessent de rejoindre la plateforme Glass. Hier, nous avons eu l'occasion de recevoir l'enregistrement du Burkina Faso. Nous les félicitons et nous atteignons, je crois, une trentaine de pays qui sont déjà dans Glass. Félicitations. L'ensemble de la région, c'est 47 pays, donc avec une trentaine, depuis plus ou moins 4 ans, nous sommes sur la bonne voie. Merci beaucoup pour tout le travail que nous avons fait ensemble. Bonne continuation et nous restons là pour vous appuyer, pour vous soutenir. Et j'en profite pour remercier HQ, le siège, les interprètes, Mauto et tous ceux qui ont contribué à la réussite de ces webinaires. La prochaine session aura lieu le 14 janvier, c'est dans un mois. Ça sera la deuxième partie sur les méthodes de surveillance de la RAM. Et là, nous allons encore parler d'autres méthodologies qui n'ont pas été détaillées ici. Nous espérons vous compter encore parmi les nôtres le 14 janvier. Il y en a qui sont en train de demander la présentation. La présentation a été envoyée à vos points focaux OMS, je crois, hier ou avant-hier. Mais ce n'est pas grave, ils vont vous la transmettre. Et sinon, je vais encore vous envoyer le lien pour accéder au website Glass 2020 pour que vous puissiez avoir accès aux consultations en ligne. Merci beaucoup et à très bientôt en 2021. Bye bye.
Merci, bonne année. Merci, au revoir.
Au revoir.
Merci beaucoup Laetitia pour cette organisation et merci beaucoup aux collègues de tous les pays. Au revoir. Thank you very much. Merry Christmas.